Good afternoon, everybody, and welcome to the Dialysis Patient Citizens Education Roundtable. We're excited today. We have guests. We're going to talk about infection prevention. And our guests today are Sunny Luna and Chuck Lizer, who hasn't joined us yet, but I'm sure he'll be with us momentarily. So without further ado, I'm going to turn this over to Dr. Scantlebury. Dr. Scantlebury?
Thank you so much, Nancy. I really appreciate this opportunity to talk about infections, which is always a major concern when it comes to patients on dialysis, because you're definitely invading the body with every time you stick yourself or every time you make a connection. And oftentimes we don't think much about it, but it can be very life-threatening. And anyone who has had an infection, whether it's a simple infection, can unfortunately become an even more severe infection and can go on to what we call sepsis. So being able to control infections while you're on dialysis becomes very important. So this is what we're going to talk about today. So we hope you in the audience, we thank you for coming and being here to engage on this roundtable conversation. And we have one guest, Sunny, and I'll let Nancy introduce her.
Sunny comes to us as one of our patient ambassadors, and she has had some kind of experience with infection. So at this time, ladies and gentlemen, I present to you Sunny Luna.
Hi, thank you. Just to give a quick background of my history, at 17, I got lupus, a senior in high school. The lupus attacked my kidneys right away. By 18, I was on dialysis, had a transplant within 6 months of the lupus destroying my kidneys. After the transplant, the lupus destroyed that kidney transplant 14 days later. So to make it quick, I've had 4 kidney transplants in the last 30 years, on and off dialysis, hemo, home, PD. So I can probably say every infection you can think of: sepsis, every bacteria infection in my ports on dialysis, 2 peritoneal peritonitis. I had peritonitis. So I've had it all. I can't even think of the one I had last year when I was in ICU for 35 days, but it was a letters, and I was searching for it in my notes. Sorry, I couldn't find it. So if there's any questions or anything that I can answer for you guys, I've been through it.
Well, thank you so much. You've definitely have had the gamut of infections. When we think about patients who, when you're first starting dialysis, if you know you're going to be, or even if it's acute, well, mostly in the acute stage, patients will get catheters placed, central lines, and that usually is the first mode of dialysis, especially if they're unknown or didn't get recognized at stage 3 or 4 and no planning. And so when patients have these access, the tunnel catheters, they're not getting stuck. And even though they need to have a more permanent form of dialysis, they want to keep these because it's more convenient. But there's also a higher risk of infections, and then you also get thrombosis in there. What was your experience with your tunnel catheters, and how long did you have those, and did you get any infections there?
Yeah, I've had I think multiple times, on and off dialysis. But my experience with the catheters was not good. Not as in pain. The pain was the peritonitis that I got twice with having 2 different catheters. But I did get an infection with both, and that's why it's not an option this time. I'm back on dialysis. And I have so I've had, the grafts from 17 and then grafts here that are no longer working, but I use my fistula now that was put in, I'd say 4 years before my transplant in 2018. And it still worked. Thank God it still worked this time when I needed it. So the fistula on the right side. But yeah, so infections, yes, both sides. So, one, when I think I first started, but it's been so long, it's been 30 plus years on and off. I'm now old, I'm 50. Um,
Not all.
so I feel so old, this time it going on dialysis at 18 or 20 or 30, I was able to handle it. I was able to go to college, I was able to do classes. Now it's taken a little toll on me, afterwards. So it's a little rougher. And I was a candidate for a fifth kidney transplant. I'm sorry, this is about infection, so I don't want to go into more detail about all that, Dr. Scantlebury. So to answer that, I don't recall so
Okay,
much an infection.
what would you say was your most disabling? You said you were recently in the ICU. Was that due to an infection as well?
It was due to COVID pneumonia.
Okay, so when you had was your peritoneal infections, were they at
There,
the same with the same catheter or with different catheters?
one time with one catheter, and then I put a new one in, and I would say that lasted 6 years, and then I got an infection.
Mhm.
So two different catheters, yeah. So
Okay.
a lot of scar tissue.
Yeah, what would you say was what would you say was your contributing factors to getting infections?
My contributing factors,
Yeah, do you think what could you do to prevent? Could you have done anything to prevent the infections?
I took really good care of my PD catheters. I had it covered all,
Okay.
all times. My husband's grandma made little pouches, and I kept it clean, did all the stuff that was necessary. The room that I was in was clean, no animals,
Mhm.
no nothing. I would wipe it down. So I felt on my end, I did do everything that I could for the
Yeah.
peritonitis.
Yeah, and that's important because some people feel, eat um, that even though that what did I do wrong? And it's important to understand that sometimes the bacteria will seep into your system because you're more immunocompromised, and you also have those barriers. It can also be from your intestinal walls, which often you get transudation. So oftentimes the infection that occur, there are some people who are on PD but may not necessarily. And you did well for 6 years before you got an infection, correct?
Right,
Well, with the second catheter, yeah. And others will have it and develop so many infections that they are unable to continue with PD because it causes loculations and you're not able to have that exchange as easy or as frequently and as effective as you did before. And understanding hopefully everyone on here is aware of, how PD is carried out, but I know a lot of people, a lot of patients tend to frown away from it because it involves them doing a lot of work and being so meticulous about the catheter, making sure it's not there's no infection, making sure that, like you said, if you have pets, you don't have them around, trying to keep the place clean. And so you also said you also had infections on hemodialysis, correct?
No, PD, the catheters I had
Yours.
here, and then
Mhm.
all the other infections I did get is being in the hospital. I got it from the hospital. Every time I would be there, I would catch another infection. It's
Okay.
nothing. The sepsis I did get at home. Uh, I waited too long when my fever was at 109. I was trying to avoid at all costs to go to the hospital. My mistake. But
So
other than
tell us about that sepsis episode and how did it occur?
it was in 2019. My son just it was his day for us to move him into UC Berkeley for college. He was a freshman. I, at all costs, didn't want to make it about me. Uh, so I tried not to tell them that I wasn't feeling well. Obviously, they knew I wasn't feeling well, but I didn't tell them the temperature was just rising. I was checking that. I was trying to take the Tylenol. I called my nephrologist and he ordered some antibiotics. We went to Berkeley, which is about 3 hours away from where I live here in California. And it was so bad. I don't remember much other than I wasn't making sense.
Yeah,
Yeah.
absolutely. And so generally, when you think about sepsis, is you have that infection that's either localized, if it's localized to the peritoneum, or if it's localized to your arm as an infection, then you get cellulitis, you get peritonitis. But when those bacteria crosses over into your bloodstream, then you're then seeding all these bacteria into your multiple organs. And so you then have a body's reaction trying to fight off that infection as those bugs go into your lungs and your liver, causing you to have problems with breathing, having problems with your blood pressure. Oftentimes you get hypotensive. And so those signs of sepsis is when your body begins to shut down. As you said, you were no longer coherent because your oxygenation, the ability of your lungs gets compromised. And so the oxygen carrying capacity is then much less in terms of, so you can have shallow breathing. Some patients will be at the point where they may need to be intubated. You had a very high fever. If that, yeah, fortunately you didn't have seizures, but sepsis and overwhelming infections can often, because of the insult to the brain and what's going on, can cause seizures to occur. And so it becomes so important to be able to um, avoid these infections, because you're then showering, if you think about it, you're showering bacteria all over your body, and then your body, the system, your body's fighting that system. You need antibiotics, you need other agents to support your heart and your blood pressure. And if you're on dialysis, it often can compromise your ability to be dialyzed because your blood pressure is already so low because of the sepsis. And do you remember how long you were in the hospital for that occasion?
I don't, but I had my transplant in 2018. That happened in 2019. So that was all me. I wasn't even on dialysis or anything like that,
Okay.
or how I got it. But I was in there, I'd say, for at least 3 weeks.
Mm-hmm.
Yeah,
Okay. So it was a long recovery.
it was.
Okay. All right. Any questions from the audience? Thank you, Arthur, and um, I see Pamela. Anyone else in the audience have any questions? Because I think it's important to think about the various phases as we one I talked earlier about those who have the catheters and the need. I see so many patients are reluctant to have these tunnel catheters removed because it's easier. And if you think about the fact that now you have this foreign body into your blood vessel, and it's generally a pretty decent size. It can encompass more than half the circumference of your blood vessel up here, which is the vein that drains the blood back to your heart, and so you can have that vessel compromised, because as that catheter is sitting there, it's going to create a fibrous capsule that's going to build up around that catheter. And if it stays too long, eventually that becomes uh, thicker and harder. And so once you take it out, you then have compromised the lumen of that blood vessel. And it makes it hard to be able to insert another catheter in that area again, which is why if after you've had one for a long time, you generally will have to have the other placed on the other side, because now getting a big catheter, if you're under anesthesia, and even for going to transplant, when the anesthesiologist tries to put that catheter in that large vein, they're not able to get it in, because now it's partially occluded, because you've caused the thickening occurring in that blood vessel. So not only that, it sets up as you get more and more foreign substance developing and forming in that in that vein, you also have more risk of infection because now it becomes a nidus for something to grow. You have a cuff, but you have pretty easy entry from the skin through the subcutaneous tissue and to that vein. And so that risk of infection is already directly into your blood. So that in itself can be an easy route for sepsis. And that's where for many patients, they then have those dramatic response to fever, chills, blood pressure worsening, and need to be hospitalized and then treated with IV antibiotics because of that.
Mhm.
Oftentimes, as you know, then you have in terms of the options for hemo, you have for those who don't have veins that are big enough, you then are not able to get the more natural, what we call arteriovenous fistula, where you then use your arterial supply to make your vein have a rapid flow and have a AV fistula will then have a foreign graft placed. And that's again another foreign substance. And that graft is then artificial tissue is placed to connect both the artery to the vein and in a way that now you have a man-made route, but is foreign tissue. And so again, you have graft. Once you have anything that's not a natural system, your body is always ready to put up a barrier against it. And because it's not vascularized in the sense of now it has no blood supply. So if there are bacteria that's getting in there, it becomes a nidus to grow within that graft. And so, which is why most people are saying if the natural route to go is an AV fistula, which would have less chances of infection because it's more natural compared to the graft, which is foreign. But now materials have gotten better, and so oftentimes if you get a blood clot or you get extravasation of blood, you're worried about whether that area will become infected because of the needle sticks directly into that area. I think I missed that question in the chat.
Dr. Scantlebury, I was going to tell you, it says, what would you recommend to patients to help keep the areas around their catheter clean to help prevent infections?
Well, generally for most, it all depends also on how the catheter, I assume you're talking about tunnel catheters as opposed to, and also PD. The difference between PD catheters and tunnel catheters is that these catheters up here, when they go into under your clavicle directly into your vein, there's very little space, but generally if they're placed correctly, they should have at least a couple of inches between the skin site, maybe an inch or two, and the site where it dives into your vein. Not a lot of space to do that, but the goal is that these catheters should have a cuff. Sometimes they put urgently and they may not have a cuff. And those are the ones which will tend to get more infected. And so it becomes important to, one, make sure you're using, oftentimes it should be, if it's with a cuff, it will seal, the skin will seal around it to decrease the chances of infection. But if you're having a catheter in your neck, it really becomes important to to keep it clean, don't get a lot of sweat under it, oftentimes follow the recommendations of your caretaker about that catheter. If you're talking about PD catheters, oftentimes the distance between, with the PD catheters, you have, there are two Velcro cuffs that keep these catheters in place. One is right below the skin, and then, and so the skin gets, and your subcutaneous tissue will stick to that outer Velcro cuff. And then the rest of the catheter is tunneled under your skin and muscle down into your peritoneal cavity. And that second cuff is then anchored right to your peritoneum and there's tissue above it so that you have a track that will keep, if you get an infection around the cuff, you have a long way, hopefully, to go. If you're really thin, you may not have a long way to go because they may not be able to have a whole lot of place to tunnel it. But the goal is that some patients can get an exit site infection. They may get an infection in the sub-Q tissue. But the goal is to have enough space to keep that infection from traveling through and getting into your peritoneum. So often the peritoneum infection may come because of, if you think about how dialysis is working inside the peritoneum, you fill in the fluid inside your peritoneum, and you have a transudation of all those substances across the peritoneum from your intestinal surface. So that's how it occurs. But oftentimes, you can have some bacteria that may leak in terms of your intestines, if you diverticuli, something that can often see that peritoneal fluid that will give you peritonitis that is totally beyond your control. But the best thing generally for PD catheters, because there's at least 6 to 8 inches between the two cuffs, and you tunnel it in an S or C underneath the skin, it will prevent exit site infection from getting all the way in. And once the skin is healed to that exit site, once that's sealed and anchored, you can't really pull it out without doing some dissection, and therefore the risk of infection should be less. But again, you still, with anything, stuff can accumulate. If you have a navel and you have an innie, you can take a bath and rinse, but you may not get all the stuff out of there. So you really want to make sure that there's not any fuzz balls or other things accumulating around the exit site. And if you just keep it clean. Some patients will have gentamicin cream or other things to make sure that there's a little bit of barrier, especially if they see any leakage, or if there's any signs that there's any tenderness, or you feel like this doesn't feel well. Bring that to the attention of your doctor, because it's so important to prevent these infections. What happens when you get continual peritoneal infections is that your peritoneum reacts, and now you have a peritoneal lining that goes from being as thin as saran wrap to now it's thicker and gets opaque, and it's more like parchment paper. And then it gets thicker over time, and the thicker it gets because of persistent infections. Also, what happens is that your bowel, instead of being free to roam around your intestine, clumps up together with a membrane, and now you're not able to have the surface area to have an effective dialysis. And oftentimes, as the thicker it gets, and the more that membrane gets thicker, you're unable to have any productive. Your PD becomes insufficient, or you're not draining well because you get loculation. So those are things to remember, because those infections, when you want to catch them early, so that you're not going on from a site infection to sepsis. Because once those bacteria get into your bloodstream and you have bacteremia, then you're called to come into the hospital, get IV antibiotics, and you want to be able to have those antibiotics into your bloodstream as soon as possible before they take nidus into your organs. Otherwise, they compromise your lungs, your breathing. They can compromise blood flow to your brain in terms of oxygenation, all those kind of things. So it's very important to remember that oftentimes, as Sunny was saying, you may not feel well. You may have some fever and chills. If you have fever and chills and really high fevers, then and you're on dialysis, you want to make sure that you let your provider know, so that they can, one, send you to the hospital, do blood cultures. If you're on dialysis, sometimes you can be introduced one way or the other. And so the goal, even as they do your dialysis, is the nurses are constantly aware of the need for sterility. When they change your catheter in the hospital, they come around to put a mask on. You do what's best to keep those bugs from getting near that site.
Dr. Scantlebury, Chuck Leiser has joined us, our second guest.
Okay.
We have about 4 minutes. Maybe you can ask him a few questions. Chuck, can you unmute so that we'll be able to hear you?
Okay, I should be unmuted.
Okay. Dr.
Oh, thank
Scantlebury?
you.
Mhm.
Welcome. Tell us, yeah, I heard you. So have you had a terrible infection related to dialysis access?
Well, I had an infection, MRSA infection in my arm. It wasn't
Okay.
actually at the axis, it was above it about 3 inches. But under
Okay.
the skin, it traveled down around my stenosis. And so they ended up, when they went in to do surgery to pull out that infection, they had to take my stenosis out. So in
Right.
essence, I don't have my fistula now anymore.
So this
Um,
stenosis was in your vein?
Yeah, it was where the vein and the artery connect, the stenosis,
Okay.
where they sew them together.
Mm-hmm.
The infection happened right next to that, which is actually about 3 to 4 inches from where I stick my first needle. So I mean, I wasn't sticking needles anywhere near it, but
Mm-hmm.
it traveled down. And so when the surgeon went in, because he said, I'll try to save your fistula if I can, but when they went in, he said that he had to tie it off because the stenosis had the infection all around it.
Right, right. So when you get a narrowing, there's often with one thing connecting to another, there's going to be areas where there a clot or platelets and stuff will gather, so you have an accumulation. Your blood cells say, okay, this is something blockage here, and so you get a buildup. And so if there's any bacteria, it becomes a nidus for just growth within that area where you have a narrowing because the cells begin to pile up. And so that's usually what happens. And that becomes, and so even if they tried to clean it out, would not be possible to get it all out without taking out the area of the anastomosis where your vein and artery came together. So
Yeah.
thank you for sharing that. So
Well, right now
Kevin?
I've got a groin catheter in because we're supposed to go in next week, and they're going to put in oh, they couldn't find a vein that's adequate in either
Adequate.
arm for a, a,
A fistula?
a fistula, so they're going to put in a graft.
Okay. All right.
They're going to do that sometime next week.
And
But
how long did
in
you
the,
have the previous abscess?
the previous fistula lasted 11 years.
Okay. Yeah, that was very fortunate to have it for so long. Yeah, definitely. I know some
But
people
I've been in,
need ballooning up that. Oftentimes it will get narrow or you get stenosis and they will go in and balloon it to try to save you. But yours unfortunately had an infection. So thank you for
yeah.
sharing.
But
All right,
like I
well,
said,
we are
now
at
I'm on the
4:30.
catheter.
Hmm?
So I said, but now I'm on the catheter,
Yes.
which I've had to have 5 of them placed in the last 10 days.
Oh,
Mm.
wow. So that
'Cause-
goes along with the difficult trying to find a place that still has an opening adequately because of the repeated usage. So thank you all for being here. Nancy, I'm going to turn it back over to you.
Well, thank you, Sunny and Chuck. Chuck, maybe we'll invite you back again so you can have a little more time. Thank you, Dr.
Yeah.
Scantlebury, as usual, and thank you to all who joined us. I want you to keep in mind that the third week in October, starting October 19th, is International Infection Prevention Week and has been designated since 1986. So be safe and thank you all for joining. Have a great day.
Thank you. Take care.
Right.